Welcome to the webinar incorporating RA therapeutic advances into patient-centered and value-based care models. This program is provided by the North American Center for Continuing Medical Education, an HMP company. This webinar is also supported by an educational grant from Gilead. I'm Dr. Gary Owens, and I'll be presenting in the beginning and at the end of the presentation basically around issues of rheumatoid arthritis prevalence and economics, as well as how payers evaluate treatments for managed care. Also presenting with me today is Dr. Leonard Calabrese from the Cleveland Clinic. Will be your presenters today. Here are our disclosures. Our learning objectives for today are to really look at the background information on rheumatoid arthritis, including its economic and humanistic burden, as well as its impact on in-plan patients. Dr. Calabrese will talk to you about some of the treatment limitations of RA management, as well as an evaluation of new and emerging oral therapies for the treatment of RA, as well as how payers will be informed to use these agents. And then I'll be closing out the presentation with some information on comparative effectiveness research and how payers need to work to reduce access barriers to patient-centric RA treatments. Let's begin our presentation today by talking a little bit about the epidemiology of rheumatoid arthritis. The worldwide incidence of RA is about 0.25%, and this is based on a bit dated information, the 2010 Global Burden of Disease Study, but it's the most updated global information that we have. However, the U.S. incidence is a little bit higher depending on which study you look at. It ranges from about 0.5% to 1%. One of the things we know for certain is that rheumatoid arthritis has a predilection to affect women, typically in a 2 to 3 to 1 ratio over men. So the lifetime risk of a woman developing RA is about 3.6%, where it's about 1.7% in men. So the bottom line is that translates into about 1.3 million Americans currently with rheumatoid arthritis, according to the best data that we have now. RA, as we know, is a disease of the joints and the connective tissue, but RA has a much more extensive disease burden than simply the musculoskeletal system. Because RA is an inflammatory disease and there are many circulating inflammatory mediators, it increases the patient's risk for many other diseases, including cardiovascular disease such as heart attack and stroke, lung diseases, many of them related directly to rheumatoid arthritis, psychiatric disorders including depression associated with chronic illness. These patients are often limited in mobility and suffer from osteoporosis and osteoporotic related fractures, and even data shows some malignancies such as lymphomas, lung cancer, and non-melanoma skin cancers are at an increased frequency in patients with rheumatoid arthritis. And overall, what that translates to is a premature mortality impact on patients with rheumatoid arthritis, with their mortality rate being 1.5 to 1.6 times higher than the general population. However, RA patients also have other long-term outcomes that go beyond just disease-related, and these are more humanistic in nature. First, as you might expect, these people have limited physical and work capabilities, and the physical impairment of rheumatoid arthritis leads to almost universal reporting of difficulty with life activities, including normal daily activities around the household. And almost 40% of patients with rheumatoid arthritis eventually will develop a work disability within 10 years of their diagnosis. And what this translates into is a reduced quality of life. And when patients are asked to report their quality of life using standardized QOL scales, most of the subscales in the quality of life measurements are reduced, including both physical and mental related quality of life. Additionally, these patients need to undergo surgery in many cases. Many rheumatoid arthritis patients undergo multiple joint replacement surgeries, and the best data we have shows that up to 1/4 of these patients will have a joint replacement within 22 years after disease onset. Additionally, The disease burden in rheumatoid arthritis is changing. As I pointed out, the disease burden of rheumatoid arthritis in the U.S. is already greater than the worldwide disease burden. But if we look at data spanning almost 2 decades between 1990 and 2017, we see some significant changes in trends. First of all, the incidence of rheumatoid arthritis in that 17-year span has gone up almost 21%. The prevalence of the disease up a bit more than 17%. And from a humanistic and societal impact, the disability-adjusted life years associated with RA is up almost 13%. So significant trends in the U.S. as compared to the rest of the world. Rheumatoid arthritis has a cost burden. Rheumatoid arthritis exerts an excessive cost and economic burden on the healthcare system, estimated to be about $22.3 billion. And why is this? In one study, we looked at pharmacy costs, office-based costs, ER and hospital costs, as well as drug and other residual expenditures. And the average annual expenditure for an RA patient was almost 3 times that of a matched control, that being $13,000 plus compared to about $4,900. Also, we know that the cost of RA treatment increases over time as function declines. And in this slide, we see that over a 30-year time span, there is a relatively linear and relentless increase in radiographic scores indicating radiographic destruction. There's a variable course of disability, but it's progressively upward. And inflammation is also variable in part due to treatment of these patients. But overall, over that 30-year time span, the direct and indirect healthcare cost of these patients relentlessly increases. But it's sometimes difficult to measure exactly the precise cost of rheumatoid arthritis. And why is that? First of all, there are really no good universal systems to track medical costs for rheumatoid arthritis patients across the multiple systems of care, that is hospital, ER, pharmacy, and doctor's offices. So we have some fairly wide ranges of the estimates of direct medical cost. We see those ranges varying anywhere from about $2,300 to more than $13,500 per patient. And in fact, if you look at multiple studies, those ranges go anywhere from $2,000 to $10,000 per year per patient, or from $5,000 or $1,500 to $22,000 per patient. And drug therapy cost is certainly one of those areas that's become an increasingly important area for payers, patients, and physicians alike. So at this point, I am going to pause in my presentation and turn the floor over to Dr. Calabrese to talk about some of the clinical issues associated with rheumatoid arthritis.
Thank you, Dr. Owens. It's my pleasure today to talk about RA treatment goal, achieving swift disease remission. Here's my outline. I'm going to do this in a few stanzas. Talk a little bit about treat to target and our rationale for early and aggressive therapy. Then I'll talk about our general approach and our armamentarium and limitations. And then I'm going to close by focusing on JAK inhibitors, which is really the new horizon in treatment of rheumatoid arthritis. So in rheumatology, treat-target approach has been canonical for over a decade. What that actually means is that we have a target as a goal, and that means that we have an instrument to use to tell us, and our target is remission or low disease activity. And when we see a patient, we measure disease activity, and if we're not at our target, we adjust our therapy until we get there. It's simple, but it is rigorous and demands that we do a number of things, including measure, focus on common patients, not the outliers. We have to wait when we start therapy. It takes, 2, 3, 4 months to generally respond. And then if we fail to achieve our target, the change modality that we're talking about, in other words, adding a drug, switching a drug, this is a part of shared and informed decision-making with our patient. and not just a matter of a rigid guideline. So implicit in the treat-to-target strategy are a number of limitations, largely based upon the measurement tools. If our goal is remission, how are we going to measure that? Well, there are a variety of metrics, which I'll show you in a minute, all of them which have limitations. The physical exam, which we do tender and swollen joints, lacks precision and accuracy. Our patient's global assessment, how are you doing today, can be influenced by everything from a headache or a backache, not just a rheumatoid arthritis, and they often don't understand this. We do use some quality of life measures, but many of them are not as dynamic as we need. And finally, we do use some laboratory tests, particular acute phase reactions like SED rate and CRP, and these are notoriously insensitive and nonspecific. So the American College of Rheumatology has undergone a search process and an evaluation process to establish disease activity measures that meet some minimum standards. And this is all evidence-based with domains set out to analyze the content. And these have been updated very recently. So this is 2019 update. They assessed 46 disease activity measures, I believe, and came out with this group of 11 that meet the minimum standards. And the ones that have the asterisks are appropriate for regular use, and they are largely clinical parameters, some addition of laboratory variations such as SED rate or CRP, but these are the ones that we are encouraged to use. I will point out that the MBDA, the multi-determinant of disease activity, which is a molecular anchor, which was developed agnostically and based on 12 different biomarkers, for the first time has entered into this. And this can be helpful for us sorting out complex medical decision-making situations. So at this juncture, let me summarize some lessons that we have learned about the treatment of rheumatoid arthritis. We're trying to avoid structural damage, which correlates with quality of life, and we know that this occurs early in disease. We also know that even achieving low disease activity or remission with our drugs is not a guarantee that structural damage may not occur. Another point that is very, very important is that early treatment is better than delayed treatment, and it actually behaves like a different disease. So that is a stimulus, an encouragement for early referral of patients for aggressive disease-modifying therapy. And then there have been a variety of studies that have supported this treat-to-target strategy, but some studies that have suggested that if we're really treating aggressively with targeted therapies and following patients the way that we should, this rigorous measurement, treat, modify strategy may not be as important as we have thought in the past. That's treat-to-target and talking about disease activity, but I'd like to just take a moment to segue to face the patient. And this is one of my favorite studies by John Davis and his group at the Mayo Clinic. And it was entitled, "Like No One Is Listening to Me." That means that even in people who achieve this rigorous treat-to-target goal, where there's tender and swollen joints are down, acute phase reactions are down, many of these patients still are failing to say, "I am totally well." And somewhere between 1 and 6 and 4 and 10, their global activity measure is not where they want it to be and not where we want it to be. And what it turns out is that when we look at those patients in great detail, there's a lack of empathic communication. And I don't want to make RA sound like a molecular disease that we just dispassionately give these advanced therapies to. There is a great room for empathic care of these patients, which really fill the void. And it has to do with listening to people and paying attention to the signals that all patients who are suffering are displaying to us. So I think this is something that we all recognize. Helpful in assessing these are the use of patient-reported outcomes. In our practice here at the Cleveland Clinic, we use extensive PROMIS metrics. These are quality of life metrics which were developed at the NIH and are free to use and can assess things like global health, global mental health, pain, fatigue, the interference of these in our daily lives, and others. RAPID-3 is a simple test for global disease activity, which has been validated across many different types of inflammatory arthritis. And it only takes a few minutes to do, and we incorporate this in our electronic medical record. Now, having said that about assessment and goal setting, why are we still searching for new therapies? Well, even though we have several handfuls of very advanced therapeutics of targeted and targeted synthetic nature, they don't work for all patients. And there's still, 1 in 3, 1 in 2 patients who don't meet the most robust goals. Real life shows that patients only stay on these drugs for X amount of time, and they're often switching. So sustained remission is uncommon. We have to be vigilant about adverse events. That often makes us change. But there is also opportunities to do this in a more exact manner, combining the voice of the patient, the use of clinical measurements and molecular disease activity markers. Now, this little cartoon, which really shows cell signaling pathways for a variety of different pathways, the mediators of which are not really shown on here. But if you go to the right, you'll see the Janus kinase pathway, the NF-kappa B pathway moving leftward, PI3, MAP kinase pathway 6, and other stress kinases. Up until recently, we have been working at attacking the disease at a molecular stage by picking off one cytokine at a time, TNF, IL-1, IL-6. More recently, there has been a lot of work done in going to the central hubs of these signal transduction pathways. And for the rest of this talk, I'm going to focus on the Janus kinase pathway, which is a central hub for cytokine signaling for over 50 different cytokines. So instead of attacking a single cytokine, we're modulating cascades of cytokines and networks of cytokines. And this has opened up a new window into therapeutic potential. So at the present, in rheumatoid arthritis, there are 3 approved Janus kinase inhibitors, tofacitinib, baricitinib, and upadacitinib, and 1 kinase inhibitor, filgotinib, which is filed already for approval in the United States and in Europe, and is undergoing assessment. And in 2020, we should know definitively whether this drug will be added to the armamentarium and under what circumstances and doses. These have been around for a number of years, so there's an extended patient experience. So what are they? Well, first of all, the Janus kinases belong to a large group of protein kinases that, for a living, transfer phosphate groups to tyrosine or serine or both amino acids for a living. There are Janus kinases are tyrosine kinases, and there's over 90 of them have been identified. These have been exploited to treat a variety of diseases, including malignant, inflammatory diseases, and is a very cutting-edge area of drug development. how they work, this cartoon shows the structural Janus kinase, and what it shows here off to its right is ATP, which obviously has 3 phosphate groups. The Janus kinase takes one of these phosphate groups and then will transfer it to another protein moiety. The Janus kinase binds to the ATP binding pocket and blocks this capacity, and thus limits its capacity to transfer phosphates. So the pathway is complex, and I don't want to bog this down, but let me make a few points. There are only a handful of Janus kinases, and they function in pairs. So when you inhibit JAK1, you will inhibit, if you look to the middle, cytokines that signal through JAK1, JAK3 pathway. And if you look to JAK2, you will find several other Janus kinases that are paired with them. So it is not straightforward one-to-one. Secondly, these JAKs then phosphorylate another set of intracellular proteins called STATs. These STATs then, once phosphorylated, oligomerize and then work their way to the nucleus, where they serve as DNA binding proteins, which then regulate transcription and translation of a large number of proteins. On the top of the receptors, you can see some of the most highly interesting candidates in the inflammatory and growth pathways that the JAKs can inhibit. Some of them are cellular receptors for growth factors like erythropoietin and thrombopoietin. Obviously, affecting these may cause off-target effects on hematologic parameters, but many of them are, center stage in the inflammatory pathways with things such as interferons, IL-6, IL-21, IL-12 and 23 and beyond. Well, the 3 approved JAKs so far have been approved in a variety of indications above and beyond rheumatoid arthritis, including psoriatic arthritis, inflammatory bowel disease, and other disorders. New indications are being looked at, including spondyloarthritis, lupus, psoriasis, varying forms of vitiligo and alopecia areata. Topical forms are being developed. So the book has not been written on these, and they're also being looked at as potential therapeutics to be used in combinatorial fashion. So the overview of these is that these are short-acting drugs. They act on a variety of JAK-STAT pathways, and it's unclear at a granular level which cell types and signaling pathways are critical in many of these autoimmune diseases. But despite these differences, the clinical responses appear quite similar across these drugs. I'm going to give you a very rapid-fire condensed view of these 4 approved drugs in rheumatoid arthritis. Tofacitinib, this drug has been around for over 8 years. It's been used on many patients, and a robust clinical development program has demonstrated its efficacy in head-to-head trials against methotrexate. Its use in patients who are methotrexate incomplete responders, who are DMARD, these disease-modifying drugs, beyond methotrexate incomplete responders, and in patients who have failed first-line biologic therapies. It can be used in mono or in combination therapy with methotrexate, and it's approved for patients who can't take methotrexate or who are intolerant to it. So a wide swatch of indications. Baricitinib, which came along in 2018, is only approved for patients who have failed tumor necrosis factor therapy or were unable to take this. and it had a very robust clinical trial development program. And like tofacitinib, it was compared head-to-head with methotrexate and looked at in methotrexate failures, DMARD failures, biologic failures, and showed to be superior to TNF inhibitors in head-to-head trials. So a very exciting drug, slightly different indications on the efficacy side. Finally, upadacitinib, the most recently approved JAK inhibitor, also the product of a very robust development program, only approved last year. Similarly, these trials, which were called the SELECT trials, looked at methotrexate-naive patients, methotrexate incomplete responders, DMARD incomplete responders, biologic failures, similar to the other drugs, and were shown to be highly effective. And all of these three drugs have shown improvement in disease activity, signs and symptoms, quality of life measures, and have shown to be effective at retarding radiographic progression. This drug in particular was put into head-to-head competition with adalimumab and shown to be superior in achieving low disease activity and a more advanced metric of disease activity called the ACR 50. So this is an important addition to our armamentarium. Filgotinib, which has completed its phase 3 trial, also has a similar design of all of these trials, looking at head-to-head with methotrexate in naive patients, methotrexate incomplete responders, DMARD incomplete responders, and biologic incomplete responders. Thus far, it has been shown to be effective at improving signs and symptoms and quality of life and radiographic progression, and will be an impressive addition to our armamentarium. This table shows the selectivity for JAKs. I told you there's a handful of JAKs, and each of these drugs may affect one JAK pathway more than the other JAK pathway. And if I had time to explain the stoichiometry here, the lower the number, the more robust an inhibitor is. And let us just say that these drugs have been described on the basis of are they a selective JAK1 inhibitor like upadacitinib or filgotinib? Are they a pan-JAK inhibitor like tofacitinib? Are they a JAK1, JAK2 inhibitor like baricitinib? Despite the differences in the in vitro assays, as shown in this slide, there is little evidence right now to suggest that there are differences in either class-derived efficacy parameters or class-described toxicity. So let me turn and talk about toxicity for a bit. Generally, the toxicity profile, safety profile, is the same across all of these agents. They are all associated with an increase in infections, and most of these are minor and not clinically important. But they're also associated with serious infections, and all of them are associated with a low incidence of opportunistic infections, including TB. Perhaps in contradistinction to the biologics that we have used for the past 20 years, the most interesting thing is that there is a class-related risk of increased incidence of herpes zoster. Most of this is monodermatomal and non-serious, but the rate is palpably increased with each of these drugs, making interest in risk mitigation with vaccination all the more important. There's also a variety of other adverse events, some of them laboratory, including dyslipidemia, cytopenias, and beyond, most of which are not of high clinical significance, but things that need to be monitored. One emerging risk from this class is a small increase in thromboembolic events and DVTs. And it is possibly related to JAK2 activity, although it is seen across all of these drugs, and thus there is a class warning. It's a very low risk, really a few patients per 1,000 exposures, but most people who use these drugs now risk mitigate by trying to avoid it in those people who have the highest risk for this cardiovascular complication. Finally, let's talk about some overview of these clinical conclusions. First, all studied parameters have been looked at across the range of immune-mediated inflammatory diseases, and they have suggested that this class of drugs is fast-acting. And in fact, it can work within a week or two, and maximum benefits come at about 3 months. Secondly, there are strong benefits on patient-reported outcomes. These are patient-facing, and that is quality of life, including fatigue, pain, and functionality. Thirdly, in combination with therapy with methotrexate, several of these drugs have been shown superior to TNF inhibitors, and as I've described previously. So that's a big step forward. And then finally, despite the difference in the selectivities I talked to you about at the biochemical level, these class-related toxicities all deserve merit, in particular serious infections, thromboemboli, zoster, and some of the laboratory parameters which we have seen. Finally, while we still await the most updated version of the American College of Rheumatology treatment guidelines, I believe they'll be in line with these very recent European guidelines, which have liberalized the place for JAK inhibitors in the treatment algorithm. 4 years ago, they were considered to be drugs to be used after first-line biologics, such as TNF inhibitors, but more recent appraisal of the strong data for all the things I've talked about show that methotrexate is still the first-line drug for rheumatoid arthritis under virtually all circumstances where it's not contraindicated or there is not intolerance. And after that, then we have to make a choice of targeted therapy with biologics or targeted synthetic therapy, of which the JAK inhibitors are. And this is opening up a new horizon for us. So in summary, early and aggressive treatment, treat-to-target strategy still has validity. We've got to think of the patient. Secondly, the targets to shoot for must be tailored to the disease and the patient with open communication and shared and informed decision-making. While biologic DMARDs have raised the bar in therapy, they're not the final answer, and now JAK inhibitors are now considered a viable option, an oral option, on par with biologic DMARDs in methotrexate intolerant or incomplete responders. So it's an exciting time to be in rheumatology, and for those that are not rheumatologists, all the more impetus to get patients to refer early for aggressive therapy to get this disease under control. So that's my summary, and I'm going to turn this back over to Dr. Owens.
Thank you, Dr. Calabrese, for that most interesting and insightful presentation on the issues associated with treatment of rheumatoid arthritis. I'm now going to talk a bit about some of the managed care issues in the management of rheumatoid arthritis. One thing we know is that the rheumatoid arthritis treatment paradigm is changing. Rheumatologists are trying to meet more aggressive treatment targets, essentially the treat-to-target approach to rheumatoid arthritis. And that means that biologics are being used more frequently and more often in the treatment of RA. And with more novel therapies out there, there are more mechanisms of actions to choose from. And the treatments are going to be more frequently switched as patients are demonstrated to have potentially inadequate response or intolerance to their current therapies. So everything is becoming just a bit more complex in RA. Payers also recognize, or they should recognize, that current practices may still be suboptimal. That's not limited to rheumatoid arthritis alone. I certainly think when we measure other suboptimal practice patterns, we see it in lots of chronic diseases, including things like diabetes and other things. But we'll focus on rheumatoid arthritis today. First, the traditional start low and go slow approach to rheumatoid arthritis still remains fairly common in RA management. And that delayed treatment and prolonged undertreatment can contribute to continuing joint damage and uncontrolled inflammation in these patients. And also, we see some hesitancy in referring some patients to rheumatologists, and those patients are often less likely to receive disease-modifying and appropriate anti-rheumatic therapy within 12 months of symptom onset. So payers should be encouraging early referrals to rheumatologists. And patients also frequently receive irregular follow-up and maybe not enough therapeutic adjustment. Again, that treat-to-target approach is not being followed universally in the treating community, although it is getting better. And so why are patients focused on rheumatoid arthritis, you might ask? Well, number one, if you look at data from the Express Scripts 2019 Drug Therapy Trend Report, you see that the drugs used to treat inflammatory conditions, and yes, I recognize that inflammatory conditions go far beyond rheumatoid arthritis and include such things as inflammatory skin diseases, inflammatory bowel diseases, and other inflammatory conditions. But a large proportion of this drug category is for rheumatoid arthritis. And as you can see in this slide, it accounts for about $200 per member per year in drug spending. And for a plan with 1 million members, that would equate to about a $200 million drug spend, and by and large is the number one drug spend at most plans in the United States now. And if it's not number one, it's certainly in the top 5 categories. So payers do have a focus on this drug category and a need to apply appropriate management techniques. As I already said, drug costs in this area are a payer challenge. The drug acquisition cost of the biologics is high, not as high as some of the areas such as cancer therapy and rare disease therapy, but because there are more of these patients often, the drug acquisition cost in aggregate is much higher than the other categories. Payers have also seen price increases as another driver of cost in the rheumatoid arthritis category. Additionally, the pipeline for RA is expanding, and those of you who are treating RA certainly know that the treatment options just in the last 2 or 3 years have expanded significantly. And this also leads to increasing and additional costs. And even more importantly, RA is a chronic and lifelong disease. Remember the 30-year disability and disease progression curve we talked about early in the presentation. That means these patients are likely going to need disease-modifying therapy over a lifetime, unlike some acute diseases like hepatitis C, which can be expensive but short-term in treatment. That being said, the total cost of care, as again we pointed out earlier in the presentation, it's difficult to assess. Even in 2020, payers have trouble merging medical and pharmacy data into a complete picture, and even if they do, those databases often aren't designed to give a complete picture because those claim systems often don't have the granularity, especially when you bring in cost of things like comorbidities, to completely and accurately assess the cost of treating rheumatoid arthritis. So what are the right treatment choices? And again, that creates some issues for payers because there are good guideline recommendations out there, but often the recommendations in the guidelines are not followed universally in clinical practice. Again, not unique to RA, but certainly what we're focusing on here. And many times the standardized outcome measures, whether those are patient-reported outcomes or composite physician and patient-reported outcomes, are not used every day in clinical practice. And many times disease progression is based on clinical assessment and clinical gestalt. Another thing that payers know is that not every biologic agent works for every patient, and therefore sometimes patients are started on an agent that is either going to be ineffective or minimally effective and will need switching. There's also really not good understanding of that variation, and even more importantly, there aren't any good biologic markers that payers can look to determine which patient will respond to which therapy. Additionally, guidelines on how biologics should be used sometimes are lacking, and both payers and physicians don't have a good stepwise flow pattern that they can use in rheumatoid arthritis. And on one hand, that's good news because it allows for individualization of therapy. On the other hand, it creates some issues for payers when they're trying to manage a complex and high-cost drug category. And so, all of the involved stakeholders, whether that's patients, physicians, and even plan managers, really need to do a better job of assessing this area. And they also, as payers, need to compare drugs, but all we have for the most part is the ability to compare drugs across studies, which has a number of drawbacks. And this is where comparative effectiveness research comes in. In a publication by my friend and colleague, Dr. Diana Brixner, at the University of Utah, Dr. Brixner encouraged all stakeholders in the process to really understand that they're often relying on incomplete data when making healthcare coverage and treatment decisions. And why is that? We have a lack of head-to-head comparisons of many competing treatment alternatives, and that's especially true in rheumatoid arthritis. And yes, some of the newer approved treatments in RA have head-to-head studies against existing treatments, but many of the legacy RA biologics don't have any head-to-head studies comparing first-generation biologic treatment. And so, as she points out, this is where comparative effectiveness research can help fill these data gaps. And that's because CER is used to compare drug therapies in the absence of head-to-head data, using a number of proxy measurements in order to do that. This slide represents a bit of the payer's dilemma, and that is payers, when they look at a drug, need to look at, number one, can the drug work? And there, they can rely on the randomized controlled clinical trials and the data published in the literature. And this is the single best source that payers have when they're assessing a new treatment. The second question payers often ask is, does it work? And there, what they really need to do is begin to merge real-world data with randomized controlled trial data. So they need to look at that accumulated evidence over time of real-world data. Unfortunately, many times at the time a payer is required to evaluate a drug at or shortly after launch, they have minimal real-world data. They also need to look to treatment guidelines and treatment pathways, but again, when evaluating a new product, very often treatment guidelines lag significantly behind the launch of new products, so they don't have much to turn to there. And then the other thing payers need to look at is, is this drug worth it? Is it cost effective? And that's where health economics research comes into play. So if you look at this slide, payers really need to merge the randomized controlled trial data, the health economics research, and real world data into a level of informed decision making that then informs formulary positions, coverage decisions, coverage policies, and even sometimes benefit design. With that, we know that if comparative effectiveness research is done effectively and well, it can lead to a number of changes in payer practice, but also clinical practice. For instance, CER can help us determine and measure improvements in outcomes. It may help us measure cost offsets, such as reduction in office visits, reduction in imaging studies, reduction in hospitalization, although hospitalization, other than for things like joint replacements and complications, is usually not a big area in rheumatoid arthritis. And ultimately, merging those data can help us determine the increased value that one drug versus another may bring to the table. And what can that do? Well, that can have a positive effect because patients can be educated on what are some of the most effective and cost-effective treatments. Providers can use that information to drive their treatment decisions or help drive guidelines, and payers can use that to inform better educated and not best estimate or best guessed formulary decisions based on incomplete data. As I pointed out in a previous slide, even benefit design can be guided by comparative effectiveness research, because if done well, comparative effectiveness research can identify key outcome measures that can help drive benefit designs. It can help evaluate drug benefit minus the placebo effect over a time period and really help determine the outcomes that are desirable and what the cost of those outcomes are going to be. And ultimately, payers are pretty simple-minded. When they look for value in a product, they're really looking at just a very simple equation, outcome over cost. And so if we can get a true estimate of drug benefit, not just drug cost, but drug benefit, that's the outcome part of the equation, and then we can put that over cost to really get what the true value of a product is. And that can help us determine which drugs are most cost effective and which drugs deserve an improved position or better access for patients on formulary. And also, I think payers need to hold industry accountable to help us support meaningful comparative effectiveness research by doing health economics outcome research in an unbiased and non-product specific fashion. And let's use an example since Dr. Calabrese talked about JAK inhibitors. This is a study, and a good example of comparative effectiveness research using JAK inhibitors. And this was published a few years back by Dr. Lee and his colleagues looking at the incremental cost effectiveness of a JAK inhibitor. And so what was this? Well, this was a cost utility analysis looking at the utility of a JAK inhibitor from a societal perspective using data out of the phase 3 placebo-controlled oral trial. And what they looked at was they looked at the efficacy as measured in the clinical trial using ACR response rates, which is a standard measurement in rheumatoid arthritis clinical trials. And they actually converted that into a composite outcome score, the HAQ-DI score, and then they used the HAQ-DI score to map utility values to ultimately calculate quality-adjusted life years, something that we're less familiar with in the U.S., but our colleagues in the UK and the European Union often make coverage decisions based on quality-adjusted life years, and eventually looked at the cost associated with these treatments compared to the quality-adjusted life year to create an incremental cost-effectiveness ratio. And I realize I've just given you an alphabet soup of algorithms, but we've tried to put what all of those are in the footnote at the bottom of the slide. And what did we find in the study? Well, the first-line use of oral JAK inhibitors increased quality-adjusted life years versus standard of care, resulting in an incremental cost-effectiveness ratio of about $13,000 per quality. Well, what does that mean? Well, typically, in a very conservative threshold, an incremental cost-effectiveness ratio of $50,000 to $100,000 is considered good value. So in this case, the use of JAK inhibitors would certainly fit well below that threshold of good value if using cost-effectiveness ratios to drive coverage decisions. And even when JAKs were used at second, third, or even fourth-line therapy, that cost-effectiveness ratio was maintained, although the numbers did go up. They also did a sensitivity analysis, which means they varied the assumptions in the translation of the clinical outcome reported in the clinical trial, and they looked at the range of ICERs based on those varied assumptions. And that sensitivity analysis showed that $13,000 was somewhat right in the middle of the sensitivity analysis numbers between $6,000 and $32,000. So what's the bottom line for all this? From a societal perspective and a cost-effectiveness perspective, the inclusion of an oral JAK inhibitor as a treatment strategy for moderate to severe RA may be cost-effective. And this is precisely the kind of analysis and investigation that payers, manufacturers, and ultimately all of us need to use to drive formulary and coverage decisions. So let's sum this up. RA is a lifetime treatment. It's a dynamic treatment, and the treatment landscape is changing as well as treatment goals are changing. The cost associated with treating RA is very high, and it's going to continue to grow rapidly, driven by more choices of therapy, more frequent changes of therapy, and the fact that this is lifelong therapy. It's getting the attention of payers, as we saw, because it's a high-cost area. But who pays for most care in the United States? Well, it's really only two sources: public payers, such as Medicare and Medicaid, and employers. And employers are also increasingly aware of the cost of RA treatments and are asking health plans to advise them on the most appropriate treatment pathways as well as the most appropriate formulary decisions. And therefore, payers need to make population-based decisions based on guidelines and algorithms and using comparative effectiveness research to drive their decisions as they manage their formularies. And that's not the end of it. This is going to get more complex because what do we know? Contracting tends to drive formularies, which means many formularies are based on legacy contracts. And why is that an issue? Because many payers in their contracts with those employers who are concerned about this cost also use rebates as an anchor for those contracts. They have rebate guarantees that they have to guarantee to these employers, and making changes in those contracts, even in an area like RA, especially in an area like RA, which is such a high-cost area, that may have impacts on their contracts with employers and the cost they charge their employers. And then that's even more important is when payers switch formularies, it sometimes places an increased burden on patients who are using a preferred formulary, and it places an increased burden on providers who must keep up with all these different formularies and different payer formularies. So in summary, spending on RA and specialty drugs is surpassing traditional agents. RA drugs represent a significant portion of the drug spend. Therapeutic options for RA are expanding, both oral and injectable options. Payers are really going to need to evolve beyond the contracting and cost-driven formulary approach to using a cost-effectiveness research approach. There's still a lot of work to be done to identify the most cost-effective areas in treatment of RA. And mostly, I think it's important for payers, patients, and the providers they work with, as well as the drug manufacturers, to break the rebate cycle and really drive formulary decisions to the most cost-effective options. And so with that, I will conclude our presentation. I want to thank you very much for attending this webinar, and we'll now open up the floor to question and answers. Okay, that concludes our didactic portion of the presentation. I'd like to welcome everyone to the Q&A session. Just as a reminder, we have a couple of questions in the queue. So we'll start, Lynn, with the first question. Is there evidence turmeric helps rheumatoid arthritis?
That's a good question. People always talk about supplements and arthritis. The turmeric, a spice we all familiar with, polyphenol in turmeric called curcumin, has been put into small clinical trials, and it has been shown to have efficacy in osteoarthritis, mild and early. And patients who want to take it, I encourage them. These are small trials, certainly not definitive trials, but at least had some effect similar to a non-steroidal, and most people tolerate this quite well, so it's worth a try.
Okay, great. The next question is methotrexate always attempted first?
Well, there's a medical answer and a real politic answer. Third-party payers will not support immediately going to a biologic, either targeted or targeted synthetic DMARD. And you have to fail a non-biologic DMARD. Methotrexate is the initial endorsed drug of choice, but about a third of people either don't tolerate it, or they may have willing to stop drinking, or they have a contraindication to it. But all sets of guidelines advocate that methotrexate is the initial trial, and we usually give it about 3 months. And if disease is not controlled, then we move on, but we generally move on by adding a biologic background methotrexate.
Okay, great. Thank you for that. And the next question is, what is the typical age of patients when diagnosed with rheumatoid arthritis, if there is a typical age?
Well, it's a disease that can occur from childhood forms to late in life. But, when we look at clinical trials, the average age is somewhere in about 40 to 50, and they've had this disease for 5 to 10 years. So, it's a disease of midlife. In the majority of people, but we have to be vigilant at all ages, and of course, female quite heavily in this, and it has about a 1% prevalence in our society, so it's not an uncommon disease. Over 1.5 million people in the United States alone.
Great. Yep, that's quite a few. The next one I'll take, is there an age limit when accessing quality of life years? And I think I probably need to talk about quality adjusted life years. They're actually a hypothetical economic concept that you basically are calculating what parameter you're interested in based on a year of perfect health. And we know that literally no one has perfect health, so you basically weigh in the various issues of the chronic disease, basic assumptions, and based on that, you can create a model that says, this is what, say, cost is for quality adjusted life year, which is what the cost of an agent would be for a theoretical perfect life year of health. And diseases that have lots of chronic sequelae, RA is one, multiple sclerosis. It takes a good number of years of treatment to achieve what would be considered a quality adjusted life year. So it's not really an age or an application, but really an economic concept that's used in modeling. So if you have to treat somebody with a treatment for 10 years in order to achieve that one quality adjusted life year, that 1 year of perfect health, you have to look at what the cost of that treatment is over the hypothetical 10 years. So I hope that answered that question. The next one, I'll take the first shot from a payer standpoint, and Len, you can have the last word. Which category of meds are being used the most? And I assume now they mean the biologic, at least from a payer far and away, not only the number one category, but the number one category of drugs by spend in the payers are the immunomodulators, of which the anti-TNFs are still number one. But that water gets muddied a little on the payer end because the anti-TNFs are used for so many other diseases other than RA, and it really gets harder for payers to break that out. But those are the most commonly used drugs from a paid claims standpoint. So, Len, I'll take it from the real world, which is when patients are being treated.
Yeah, I think that clearly the biologics and TNF inhibitors that we've had for now 20 years are the first line of therapy for patients failing, traditional DMARDs. But the past 5 years has seen a liberalization and a move toward losing the exclusivity of having to start with a TNF inhibitor. And, there are other molecular targets, other cytokines, and now targeted synthetic therapy. So I suspect there'll be an evening out of what the next line of therapy will be, based more on comorbidities and ultimately, hopefully, biomarkers, which we don't have yet.
Okay, great. Well, that bumps us right up against the end of our time period. So this concludes the question and answer session. I will ask those of you in the audience, please be sure and complete the evaluation on the program page that you'll be redirected to as soon as I'm finished here. You need to do that in order to claim your credit. So with that, I'll wish everyone a great afternoon.
Me too. See ya.
Take care. Bye now.